The next topic is renal cancer. Renal cancer may be benign or malignant, may be unilateral or bilateral. The common sites of metastasis are bone, lungs, liver, spleen, or the other kidney. The risk factors include men, obesity, exposure to industrial chemicals like petroleum products, heavy metals, and asbestos, tobacco use, polycystic kidney disease, and unopposed estrogen therapy. The signs and symptoms, mostly there are no symptoms, especially in the early stage. In some or in later disease, dull flank pain, palpable renal mass, painless gross hematuria is seen. Symptoms from metastasis may be the first manifestation of renal cancer, which may include unexplained weight loss, increasing weakness, and anemia. Treatment is usually a combination of chemotherapy and surgery. Radiation therapy may be used for palliative therapy. Kidney surgery. Kidney surgery involves inserting a nephrostomy tube or a ureterostomy tube, partial or radical nephrectomy for extensive kidney damage, renal infection, severe obstruction from stones or tumors. Radical nephrectomy involves surgical removal of the entire kidney, adjacent adrenal gland and renal artery and renal vein. Pre-op care includes standard pre-op care, reducing anxiety through pre-op teaching about the surgery, post-op course and care, possible tubes and drains, pain management, teaching about incisional pain and importance of deep breathing, turning and coughing every 2 hours to prevent atelectasis, early ambulation to prevent DVT. Post-op care includes airway clearance, pain management, monitoring vital signs, bleeding, splinting incision with hands or pillow to help with deep breathing, assist with early ambulation, encouraging incentives spirometry 10 times every hour, assess hourly urine output. Urine output must be at least 30 mL per hour, monitor aseptic precautions while taking care of patients, monitor indwelling catheters, tubes, and drains, IV site, incision site for infection, irrigate the nephrostomy tube if prescribed, maintain adequate fluid intake, maintain bleeding precautions, use of anti-embolism stockings, SEDs, maintain fluid status in ambulation to reduce the risk of thrombosis. This is the positioning during kidney surgery. It's either the flank approach, the lumbar approach, or the thoraco-abdominal approach. Kidney transplantation. Kidney transplantation has become the treatment of choice for most patients with ESKD. The cost to maintain a successful transplant is 1/3 the cost of dialysis treatment. Kidney transplantation involves transplanting a kidney from a living or deceased donor to a recipient who no longer has renal function. Donors are screened for ABO blood group, tissue-specific antigen, human leukocyte antigen compatibility, and the presence of any communicable diseases. Cadaver donors must meet the criteria for brain death. Continuous ventilation and normal blood pressure and heart rate are maintained until the kidneys are surgically removed. Warm ischemic time is the time between cessation of perfusion and cooling of the kidney and the time required for anastomosis of the renal arteries and renal veins. The maximum warm ischemic time is 30 to 60 minutes. And if the kidney has been cooled well, the maximum transplantation time is 72 hours. Contraindications include recent malignancy, active or chronic infections including AIDS, severe irreversible extrarenal disease, active infection with Hep B and Hep C. Nursing management involves urine output starts almost immediately if live kidney transplant. It may be delayed for a few days if a cadaver transplant is done. Hemodialysis is continued until adequate kidney function is established. Monitor vital signs, hourly urine output, administer IV fluids, daily weights, Monitor daily lab results, serum creatinine, BUN, electrolytes, hemoglobin, and urinalysis. Position patient in semi-Fowler's position to promote gas exchange, turning from the back to the non-operative side. Monitor Foley catheter. Urine is initially pink and bloody, but gradually returns to normal within several days to weeks. Notify if gross hematuria and clots in the urine. Monitor three-way bladder irrigation if prescribed. Remove Foley catheter as soon as possible to prevent infection. Maintain protective isolation precautions, including having the patient wear a mask when out of the room, monitor for infection, monitor for bowel sounds, maintain good oral hygiene, encouraging coughing and deep breathing exercises, administer medications including antibiotics, antifungal, immunosuppressant, and corticosteroids. Patient is usually ambulated after 24 hours. Assess organ rejection, including signs and symptoms that include fever, pain, tenderness, and distension over the grafted kidneys, 2 to 3 pounds weight gain, edema, hypertension, malaise, deteriorating renal function, elevated BUN serum creatinine levels, elevated white blood count, or leukocytosis. Rejection can be hyperacute, that is rejection occurring within 48 hours, or acute rejection, renal failure occurring within 6 weeks, and chronic rejection, which occurs slowly from months to years and mimics chronic kidney disease. Home care includes verbal and written instructions regarding follow-up, diet, medications to maintain immunosuppression, fluids, daily weight, urine output, prevent infection, avoid contact sports, avoid prolonged periods of sitting, recognize signs and symptoms of rejection, avoid exposure to persons with infections, and information about local transplantation support groups. As seen in the picture, the recipient kidneys are not removed. The transplanted kidney is placed in the right iliac fossa or sometimes on the left. Once blood supply is established, the urine should begin to flow, which indicates the overall success of the transplant. Renal replacement therapy or hemodialysis. Hemodialysis is used when patient is acutely ill until the kidneys resume function and for long-term replacement therapy in CKD, or in other words, ESKD. The objective is to extract toxic nitrogenous substances from the blood and to remove excess fluid using the process of diffusion, osmosis, and ultrafiltration. The four parts of a hemodialysis are the dialyzer, the dialysate, vascular access, and the hemodialysis machine. Dialyzers are hollow fiber devices containing thousands of tiny capillary tubes that carry the blood to be dialyzed. The tubes are porous and act as a semi-permeable membrane. The dialysate is also called as the dialysis solution or bath and consists of water without chlorine, electrolytes, salts such as sodium and bicarbonate. The dialysate pulls toxins from the blood into the dialysate by diffusion. The vascular access may be the AV fistula or the arteriovenous graft or a temporary HD catheter or hemodialysis catheter. The hemodialysis catheter is manipulated only by the dialysis RN. Hemodialysis is usually done 3 days a week for a period of 3 to 4 hours. Dialysis may also be performed in non-CKD patients in times of emergency, like hyperkalemia, fluid overload, uncontrolled hypertension not controlled by different antihypertensives and diuretics, excessive pruritus, seizures due to uremia and uremic syndrome. The AV fistula will take about 2 to 3 months to mature before it can be used. Collateral circulation develops below the level of the fistula. To promote development of collateral circulation, small hand exercises are encouraged. The patency of the AV fistula is assessed with a positive thrill and a bruit. A stethoscope is placed over the AV fistula and a whoosh sound is heard. The thrill of the blood flowing is felt upon placing 2 to 3 fingers over the AV fistula. Blood pressure and venipuncture is not performed on the arm with the fistula. Do not sleep on the AV fistula side. Carry heavy weights, wear constrictive clothing or jewelry, or wear the shoulder bag on the AV fistula arm or on the side of the AV fistula arm. Keep the fistula firmly covered soon after dialysis, as there might be some amount of bleeding. Prevent infection of the AV fistula. The hemodialysis system. Before the procedure, the client's weight and vital signs are taken. Orthostatic BP is usually taken. Protective eyewear, gown, and gloves are used for protection during the procedure. AV fistula have the best overall patency rates and least number of complications, like thrombosis and infections of all vascular accesses. The needles used for hemodialysis are large bore, usually 14 to 16 gauge, and are inserted into the fistula or graft to obtain vascular access. One needle is placed to pull blood from the circulation to the HD machine, and the other needle is used to return the dialyzed blood to the patient. The needles are attached via tubing to dialysis lines. Dialyzer or blood lines are primed with saline solution to eliminate air. Heparin is added to the blood as it flows into the dialyzer because anytime blood contacts a foreign substance, it has the tendency to clot. Patients are closely monitored for hypotension. Dialysis is terminated by flushing the dialyzer with saline to remove all blood, after which needles are removed and firm pressure is applied. Before treatment, the nurse should complete assessment of fluid status, condition of access, temperature, skin condition, the difference between the last post-dialysis weight and the current pre-dialysis weight determines the ultrafiltration or the amount of weight to be removed. Since antibiotics and other medications can get dialyzed out, they are withheld before the dialysis. During treatment, nurse should be alert to changes in condition and so measure the vital signs every 30 minutes. Complications of hemodialysis. Hypotension that occurs during hemodialysis occurs primarily from rapid removal of vascular volume or hypovolemia. The drop in blood pressure can result in lightheadedness, nausea, vomiting, seizures, vision changes, and chest pain from cardiac ischemia. The treatment for hypotension includes decreasing the volume of fluid being removed and infusion of fluids during dialysis. After dialysis treatment, fluid boluses are not recommended. Hypothermia is common during post-dialysis due to removal of fluids. Warm blankets are provided. Muscle cramps are expected due to rapid changes in the electrolyte levels. Most patients post-dialysis report tiredness and fatigue. Allow rest. Avoid showering, bathing or swimming for several hours after dialysis. Blood loss may result from incomplete rinsing of blood from the dialyzer, accidental separation of blood tubing, dialysis membrane rupture, or bleeding after the removal of needles at the end of the dialysis. Firm but not occlusive pressure on the access sites is used until the risk of bleeding has passed. Disequilibrium syndrome occurs during or soon after hemodialysis. Rapid decrease in fluid volume and BUN levels cause this. The change in urea levels can cause cerebral edema and increase intracranial pressure. Neurological symptoms can result like headache, nausea, vomiting, restlessness, decreased level of consciousness, seizures, coma, or death. This can be prevented by starting hemodialysis for short periods with low blood flows so that rapid changes in plasma composition are avoided. For severe cases, early recognition and treatment with anticonvulsants and barbiturates and slow infusion of about 250 mL of normal saline may be given. Most often, seizure precautions are instituted. Dysrhythmias results from electrolyte and pH changes. Vascular access problems, including thrombosis, aneurysms, ischemia, and infections may occur. TPA may be necessary to declot the access. Sterile techniques are used to prevent infections. Aneurysms are caused by repeated needle punctures at the same site. Ischemia occurs in a few patients with vascular access when the fistula decreases arterial blood flow to area below the fistula. This phenomenon is referred to as the Steele syndrome, and the symptoms can vary from cold or numb fingers to gangrene. If the collateral circulation is inadequate, the fistula may need to be surgically tied off and a new one will need to be created.